My name is Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I am a thoracic medical oncologist, and I'm a member of the Institute's thoracic oncology program, actively seeing a large volume of lung cancer patients, as well as continuing many clinical investigations in the thoracic malignancy space. There's kind of two aspects to this question. Let's deal with the use of steroids to treat an immune-related adverse event. So let's say you have a patient that starts on treatment and at some point down the road has a grade 2 or grade 3 adverse event that is felt to be related to the immunotherapy, so an immune-related adverse event. The use of steroids, I'm not aware of any data to suggest that the use of steroids in any way impacts on the efficacy of the immunotherapy in that population. There are other disease states such as melanoma, in which the data has suggested that is also true. So if you have to use steroids, even high-dose steroids, during the course of treatment to control an immune-related adverse event, I don't believe that has a major impact on the efficacy of immunotherapy, which usually has probably already occurred by the time you identify the immune-related adverse event. So I am aggressive about using steroids in the event of an immune-related adverse event because I think that my goal is to prevent them from being any worse than grade 2, getting them under control and resolved to grade 1 or perhaps grade 0. Allows you the opportunity to use your judgment in terms of reinstituting immunotherapy. Part of that would be dependent upon what's going on with the underlying tumor response and those sorts of considerations, and perhaps the nature of the immune-related adverse events. I'm much more conservative in, say, pneumonitis than I am, say, in dermatitis or colitis or other entities such as that. So that's how I think about the use of steroids to control immune-related adverse events in patients that are on immunotherapy. I think the other part of the question is, what about those patients who are using steroids prior to starting immune therapy? We don't have much data in this area. There was an abstract presented a couple of years ago at ASCO by one of the Memorial Sloan Kettering physicians looking at this question. It was a retrospective chart analysis that suggested that those patients that required higher doses of steroids, certainly higher than the equivalent of 10 milligrams of prednisone on a daily basis, did not fare as well. And then the question comes up, is it, why were they on steroids? What was the comorbid situation that required them to be on steroids? And is it really the steroids, or is it the comorbidity of the patient that really interfered with, because immunotherapy seemed to be less effective in those patients. But I would argue that it's a concern, but it's not a conclusive study in terms of blaming the steroids in and of itself, because I think in general, these were kind of poor protoplasm patients that were evaluated that needed to be on higher dose steroids because of some comorbidity. Now, obviously, all of the initial clinical trials restricted these populations, so we don't have any prospective data looking at patients with higher than the equivalent of 10 milligrams of prednisone a day. So I'm not aware of any prospective data as the clinical trials excluded these patients. So we don't have data from the existing database from a clinical trial point of view that would help us in this area. So I think in terms of clinical practice, I think we have to be aware that there is a concern that the outcomes with regard to the effectiveness of immunotherapy may be compromised in those patients that require higher doses of steroids. But is it necessarily the steroids itself, or is it the fact that the patient had some comorbid condition, perhaps a poor performance status, and that really is driving the outcome more than it is per se the steroids in and of itself.